Hello, everyone. Welcome to Everything Parkinson's, our monthly webinar. Today is a very special day. We do have Dr. Petrosian back on our webinar series. It is going to be a very important topic that we're going to be discussing today. We're going to be talking about behavioral issues in relation to Parkinson's. So this includes your hallucinations, delusions, and impulse control disorder. So Dr. Petrosian is definitely not a newbie. In fact, she's a very familiar face in our webinar series and doesn't really need any introduction. Let me just Dr. Petrosian, I added you as panelist. Okay. So without any further ado, let's please all welcome Dr. Petrosian.
Hi, guys. Thank you for joining us. Giselle, I guess I will share my own screen. Oh, if you don't mind allowing me to share my screen. Maybe I'll try that again.
Give me 1 second, Dr. P.
Sure. Okay. I did want to start off with a disclaimer that this is a very, very sensitive topic, and people get very nervous about these symptoms. And if you are joining us or watching online and you're not experiencing any of this, or your family member is not experiencing any of this, it's important to bear in mind that these are not universal symptoms of Parkinson's, and therefore it's important to keep that in perspective. Let me see. Oh, it looks like you have made it happen, Giselle. Thank you. I'm going to close that and start that. Yes. Okay. So I started subtitles so that people can follow along as I speak, and I will click here. Okay. So just to give some brief overview of what we're going to be talking about, the term psychosis refers to a disconnect from reality. And that includes hallucinations, illusions, and delusions. And we'll get into more detail about all three, but there is a very, very, very wide range of what these experiences can include. And then we will discuss impulse control disorders, including punding. So talking about hallucinations versus delusions. So an illusion is a misperception. And a good example of that would be mistaking something for something else, such as thinking that one is seeing a mouse and then looking again and realizing that it's a computer mouse or something like that. Hallucinations can occur with or without insight, and they can occur in primarily visual modality, but also occasionally auditory and tactile. We'll also be discussing delusions, which are fixed false beliefs. And the totality of these symptoms are experienced by 20 to 40% of people with Parkinson's. But if you read the studies, there's such a wide range depending on how they define it. If they include minor illusions, then the rate can be as high as 50%. If they're only thinking about delusions, it's more like under 20%. And if they're looking at a population that is already in an advanced stage, then it is a higher percentage. So illusions are very interesting. Again, as I said, these are triggered by a stimulus, and these tend to be visual first and foremost. And there is a term called pareidolia illusions, where pareidolia phenomena are actually very normal. So I think that people can see some faces in these 4 images that I've put up here. And none of that is a hallucination, or an illusion for that matter. It's just the way our brain is really defined at, essentially 2 weeks of age, to look for 2 areas of darkness next to each other and 1 area of darkness below it and kind of in between that. And that is the vision of our mothers, typically mothers or caregivers' faces. So really, really hardwired to see faces and other types of figures in non-facial patterns or other kinds of patterns. But the challenge can occur where people can experience a broader disconnect from that stimulus to being more convinced of there being, again, something within that pattern, or like an animal, other kinds of figures. Sometimes it can be a blanket becomes a woman, or a wire may become a snake. But illusions are, by definition, triggered by the stimulus. Hallucinations are not triggered by a stimulus. They are they come on their own. Again, the majority of hallucinations experienced by patients with Parkinson's are visual. It tends to be animals, insects, or people in the room, or perhaps outside the house. When the hallucinations are auditory, they tend to be sounds of music or dinner party type voices or footsteps, thinking that you're hearing somebody in the home and there's nobody else there, or not being sure of how many people are in the home. The difference between the hallucinations of conditions like Parkinson's and other neurological conditions versus the hallucinations that occur in primary psychiatric conditions like schizophrenia and bipolar disorder are that more typically in the latter, the auditory hallucinations are much more prominent, and they tend to hear voices speaking to them. So the voice of some other person or some other entity saying something negative about them or directing them to do something. And that is extremely, I would say, it really does not happen in people with Parkinson's. Like, even if there are voices that are being heard, it tends to be more of a dinner party phenomenon where there aren't any clear understandings of what is being said. Just like you hear that murmur of people talking, but you have no idea what's being said. Also, again, I think it's important to clarify that hallucinations that are described in, Hollywood are very different. Like, I remember in that movie, A Beautiful Mind, spoiler alert, there was like a whole character who was this visual, hallucination that was just talking to that person, like that they were actually kind of like looking like another character in the room. And it really is not how people describe these hallucinations. There may be a sense of there being a person there, but that person is very unlikely to interact with the person who's experiencing the hallucinations. I've had cases where people will avoid sitting in a certain spot because they believe that there's a person sitting there, but they won't describe it like that person is going to get up and start talking to them and chit chat about their day. So, be very, very cautious of the way Hollywood portrays almost anything in medicine, but certainly in the case of hallucinations. So tactile hallucinations can include the sensation of bugs crawling or other abnormal sensations on the skin. And hallucinations can be simple or complex. So a simple hallucination would be like bugs or spots, whereas something more complex would be, again, as an example from my patients, I had a gentleman who would see a person wearing a Letterman jacket, and it was always the same red and white Letterman jacket. It wasn't necessarily a person who he knew, and again, that person wasn't interacting with him, but it was very complex and stereotyped that it was this Letterman jacket, excuse me. Now, people with Parkinson's can often describe what are called passage hallucinations or presence hallucinations. And again, these are very, very vague and very simple. They're not, I think a lot of people wouldn't even necessarily use the word hallucination to describe this, but passage means a sense of something or somebody passing in the peripheral vision. And then presence would mean, like, again, usually peripheral vision, like, let's say kind of sort of behind somebody, this sense of, okay, there's somebody else there. And then usually what they'll describe is they'll turn their head or their eyes and look at wherever they think they're seeing something, and then there's nothing there. So that is something where, especially if somebody does have a pet, is there a cat? Is there not a cat? Are they there? Are they not there? These are very common and typically extremely minor and not bothersome to the patient. And so that gets into the concept of sort of this quite broad range of the severity, where the vast majority of people who are experiencing hallucinations in earlier stages of their condition are really not particularly bothered by them, especially once they realize that they understand what's happening. Because if they just look again, or maybe they blink again, or maybe they turn the light on, that image will go away and they are not bothered by it. Interestingly enough, I've had people tell me that they actually find their hallucinations to be a comforting presence, that they feel like they have company and they don't mind it. I know it sounds bizarre, but I have had people tell me that their hallucination is like a friend who comes to visit. So, I think that it's important to bear that in mind, that while there can be quite distressing hallucinations, when people think about and worry about getting hallucinations, I don't think anybody would imagine it being something that might be a comfort or even a benign experience. Sometimes the hallucination can be confusing, where they'll be not sure about it and want to ask a family member, oh, did you see that person? Is there a person outside the window? Or how many people are in the room with us right now? And then once that family member has, or care partner has clarified how many people are in the room, then they're comforted by that and they feel comfortable with the response. However, issues can arise when there's a lack of insight and an inability to accept what the ostensibly reality is, in terms of, disagreeing about whether or not there is a person in the room with them or outside the room, or whether there are bugs or not. That can be quite bothersome. In general, it's thought that as the condition progresses, people's hallucinations can shift from being initially minor or benign to being more problematic, more loss of insight, and more modalities, including the auditory and tactile modalities. But in no way would I want to suggest that this happens in a straight line or that it is inevitable for people. Delusions are defined as fixed, false, idiosyncratic beliefs that are maintained despite evidence to the contrary. Now, we don't want to get too political about a lot of beliefs that people are holding these days that seem to be completely disconnected from reality. So I think we'll say that if there's a sort of a shared belief in something that there's no evidence for, or there's evidence to the contrary for, then maybe that's more of just what's the word I'm looking for? Conspiracy theory kind of thing. So we won't count that, but really would be something that doesn't feel like it's true to what the patient should believe or would believe in other situations. So for example, being paranoid about somebody is stealing from me, somebody is cheating on me, somebody's out to get me. Those are called paranoid delusions. Delusions of reference are better described as misidentification. So my loved one isn't who they say they are actually an imposter or an actor. And that is actually, there's a name for that because it happens frequently enough, which is called Capgras syndrome. Sometimes people will tell me that there are two, Giselles, let's say, and this isn't the real Giselle, she's somebody else who is pretending to be Giselle, or they may not even get to that kind of level of being able to say the other Giselle is an imposter, but just the sense of there being two people who are both claiming to be Giselle. And I had a case where a patient through his he thought that he was driving with his wife was driving, And he thought that this person was the imposter and that she had stolen his wife's purse and like opened the door while she was driving to throw the purse out or escape. It can be very dangerous, to be honest with you. These can be really, really difficult for a family member. To be, honest, the reality is that it's important to try our best to recognize that this isn't anything intentional, that this is the disease causing it, but we're all humans, and it can feel very it can be very emotional to recognize that a family member is claiming that we're not who we say we are, or that we're out to get them, or that kind of thing, when they're just trying to be of help. So these are really, really challenging for the family member. Reduplicative delusions refer to the belief that a room or a place has been duplicated. So for example, they may feel that somebody has brought in a set and all of the furniture in the room is this replica of the reality, and that they are not where they say they are. They don't feel like they're at home. And that is something that, points to the issue of delusion, which is that it's really difficult to argue with a delusion. Once a delusion is in place, generally speaking, even if you, as I said, bring evidence to the contrary, that belief is still going to remain in place. And so it can actually result in more arguments of saying, well, no, look, this is our book. Don't you remember this is our book? Well, no, that one got ordered from Amazon or whatever. There's commonly arguments that occur to it. So it's important not to try to logic one's way out of a delusion, because oftentimes that's not going to be fruitful. So it's usually better to sort of acknowledge that this person is experiencing this that is very distressing to them. Another delusion that can occur is the mirror sign, which is the failure to recognize oneself in the mirror. And then much less common are somatic delusions or guilty delusions. And again, as I said, this occurs in under 20% of people with Parkinson's, depending on the study that's read. So how do we differentiate between visual changes that occur, and how does vision play a role in the illusion or the hallucination? Because the reality is that low light and low vision can contribute to visual changes and illusions and hallucinations. And that makes sense. If when the light's turned on and it's clearer and brighter, or you put your glasses on and you can see it, well, actually it isn't a snake, it's a cord or whatever. So it is really important to have the eyes checked once a year and to consider what the light may be doing or lack thereof. So for example, sometimes there's a lot of shadows coming in from the outside, and the shadows make it look like there's a jaguar in the tree. So maybe the answer there would be to get blackout curtains, or if there's a way to turn off outside lights, to turn those off. Or if there's a lot of hallucinations happening in the bedroom at night, then, before getting out of bed, turn on the lights or use a motion activated night light to bring more light at night when they're awake. Obviously, it's best to sleep in a dark room. But there are other visual phenomena that occur that have nothing to do with Parkinson's and may require one to see their ophthalmologist sooner rather than later, especially if they are acute, meaning a significant change in the symptoms. So sparks, floaters, shooting lights, lightning streaks, that's on the bottom left with that picture that looks sort of like bacteria floating in the sky, especially if they occur suddenly in one eye only, or are accompanied by eye pain or loss of vision in one eye. Those could represent an ocular emergency. So don't think that anything visual is a Parkinson's thing. There can be other issues involved. So again, that wouldn't be necessary to see an eye doctor for. Ocular migraine can cause visual changes. So typically that would be like a zigzag line, kaleidoscope, or what are called scintillating scotomata, which is like an area of the visual field that's especially peripherally that is blocked out with sparkling lights around it that are sort of moving and twinkling a little bit. And that can be in both eyes. It can be accompanied or not with headache. And that, again, has nothing to do with Parkinson's. So reasonable to ask your eye doctor or a neurologist about if those types of things occur. There are other ways that the vision is impacted. Or sudden loss of vision in one eye should absolutely get checked out to make sure it's not a retinal stroke or a brainstem stroke or a cerebellar stroke or something like that. So again, we should not be assuming that everything is from Parkinson's. I know that I have a bad bias that way, so I hope not to compound that today. So what are the contributing factors and risk factors for hallucinations? So medication could play a role, but to be honest, the role of medication in PD psychosis is controversial. They can occur in unmedicated patients, especially the milder ones like the passage or the presence hallucinations. But certainly there are, if there is a clear time frame where a medication was started and then hallucinations began, then really we want to first start by taking away any potential instigators. Because hallucinations and psychosis tend to occur in later stages of Parkinson's, because the vast majority of people with Parkinson's are taking levodopa, it can be really challenging to know whether it's playing a role. But generally speaking, if the dose hasn't really changed and the symptom is progressing, then I tend not to assume that it's from especially levodopa. And it's really kind of the lower one on the risk in terms of potential cause. The bigger causes are going to be anticholinergics such as oxybutynin, trihexyphenidyl, amantadine, dopamine agonists, and reasonable to try to take away what's possible. But of course, as a reminder, nobody should be making any medication changes without discussing their issues with their treating providers. Cognitive dysfunction is associated with severe visual hallucinations, but not as much with minor hallucinations. And the other way to frame that is that if people are experiencing minor visual hallucinations, such as the passage or the presence, they should feel a little bit more confident that there was a study looking at the cognitive function in people, comparing them to those who did not have those minor hallucinations, and there was no difference in that time frame. It can be associated with lack of sleep, of course, gene mutations in the GBA gene, and autonomic dysfunction. And again, when we talk about risk factors, we're not talking about necessarily that these are causative, just things that are associated. So management, definitely ocular evaluation, hearing evaluation, eliminating potential triggers can often do the trick. So if there is something, especially in the bedroom or in an area of low light, like at night, and it is consistently being the nidus for a visual hallucination, getting rid of that may be all that it takes to get rid of that that illusion. So for example, a coat rack is turning into a person, or there's a lot of clutter and blankets and pillows and things like that, making it seem like there's people. Sometimes just getting rid of or switching the location of pillows and blankets can be enough. Especially if there's something that has a very busy pattern in it that has a tendency to look at eyes. I'm actually looking at something right now that has like this floral background, and there's something that kind of looks like eyes on that. So that kind of thing, maybe I switch that out and put something plain up so that it isn't triggering things. It actually really can make a difference. Again, as I said previously, minimizing unnecessary medications and improving the sleep-wake cycle. Now, again, if these things are occurring on a very acute basis, like no hallucinations and then all of a sudden start hallucinating, that can occur in delirium, which can occur in things like urinary tract infections or after anesthesia. So if hallucinations only occurred after anesthesia, it doesn't necessarily mean they are going to continue happening. So again, important to just sort of, sometimes it's important just to wait it out and see if things get better on their own. I do want to also emphasize the importance of not fighting the patient on it. It's reasonable to sort of gently redirect and say, it's just the three of us in the room right now, if the person is confused about how many people there are. But if they argue, no, I see these people here, if they're really sticking to their guns, really important not to engage in an argument. So saying something like, I know that you're seeing a lot of people in the room right now, and I can understand that would be really scary for you. Why don't we go outside and take a walk, or go look outside the window so that there's a little bit of a change of pace? That kind of concept of recognizing, acknowledging the emotional situation that the person is in, and trying to see if redirecting helps. But really trying not to engage in long logical loops about things. And again, this is really hard for people to do, because if somebody's being accused of infidelity, then, it's hard not to defend one's honor, but, trying to limit that to the sort of, okay, we tried to give some information and then move past that. So the only FDA-approved treatment for PD psychosis is pimavanserin, which is known as Nuplazid. It is not a dopamine blocking medicine. It works on the serotonin receptor. It's a once-a-day medication with or without food. It can improve hallucinations by making them less severe, less problematic, less bothersome in the majority of patients. There is a subset of people who don't respond to Nuplazid. There's a subset of people who respond very dramatically and find it really, life-changing in a positive way. But on average, there is an improvement, not necessarily a 100% improvement in everybody, but enough improvement that for most people, they find it beneficial. However, it can cause QTc prolongation, and there is a black box warning on the label for its use, just as there are with any antipsychotic medication. So I don't use this medication for mild or minor or benign hallucinations, only if the hallucinations have gotten bothersome enough to be problematic for the patient or for the caregiver. And it can take about a week or sometimes two to become effective. Quetiapine has been very commonly used, although the evidence supporting that is essentially, I would say, anecdotal in terms of that experiential evidence and not, randomized controlled trial evidence. But doses are used from 12.5 to around 150 milligrams. It can be sedating, so it can be more beneficial when the hallucinations are contributing to lack of sleep, or there's significant lack of sleep contributing to hallucinations. Again, EKG needs to be monitored. And clozapine is effective. It is an antipsychotic medication, but it does require monitoring of the white blood cell count very strictly, using a registry, so therefore it's used very rarely. So moving on to impulse control disorders. So these can include compulsive behaviors such as gambling or risky investing, shopping in a, addictive kind of way, I would say, overeating, video games, smartphone apps, sexual impulses or behaviors, alcohol or drugs less commonly. And we'll talk separately about dopamine dysregulation syndrome. Punding is the term for a particular type of compulsive behavior, which is a repetitive, non-goal oriented complex behavior, such as rearranging drawers, shuffling papers, tinkering with, equipment such as watches or clocks or even cars, emptying purses or wallets. And often these things are characterized by an inability to put things back together. And so it's very different from, oh, I'm going to clean out my closet and, organize everything. It can be actually quite problematic when everything's getting taken out, but hard to put things back in. Especially if there's a car involved or a clock or a watch, I imagine. And then finally, there's a less common condition called, well, I wouldn't say less common, but just less commonly described condition called walkabout, which is sort of this restlessness with a strong urge to walk around in a sort of impulsive way. So there is a relationship between these three phenomena where there's an overlap between the impulse control disorder, the dopamine dysregulation syndrome, and punding, which can occur in isolation or in combination. So how or why does this happen? Well, it's because dopamine isn't just involved in the movement pathway, which is shown in green here, but it's also important for what we call executive function, which is the blue one on top, and in the reward pathway, which is the red mesolimbic pathway shown on the bottom. So every decision that we make is always based on a subconscious risk reward analysis. So literally every decision that we make. Should I brush my teeth this morning? Should I go to the gym? Should I eat this donut? Should I, bet $1,000 on red? Now, the majority of our decisions are subconscious. Really, a very tiny minority of the behaviors that we have and the things that we do in our entire lives are actually done with any mindful, conscious decision making, like, should I buy this house, or should I become a neurologist? Those kinds of things tend to be a bit more conscious, but almost everything else we do in life is really very subconscious. And this is obviously not just a Parkinson's thing. This has huge implications for how people live their lives in general. But in the context of the impulse control disorder, people who have impulse control disorders are noted to have brains that signal more interest in, or more visceral, if you will, enjoyment of the reward, and minimal signals alerting for risk. So they're very much desensitized by negative consequences. So that whole risk reward kind of balance shifts, where people just don't recognize viscerally that kind of anxiety or fear of, like, well, what would happen if I bet 1,000 on red and it turns up black? What's going to happen to me? That almost anticipatory anxiety is really suppressed, and the kind of that enjoyment of, that experience right as that ball is rolling through, what is the potential reward that's going to come out, that is magnified and really feels like it's a much bigger reality, or a much bigger probability than the probability of the negative consequence. So there's been some really interesting experiments that have kind of clarified that. So there's a overlap between patients with Parkinson's who have impulse control disorders and people who have addictive behaviors in absence of Parkinson's, such as people who are gambling or drinking or drugs, etc. But one of the differences is that with some impulse control disorders, such as punding, for example, it's not really about the reward people get from doing it. It's just sort of this loop that occurs without the concomitant reward. So this can be experienced by about 10 to 20% of patients, but it is higher in people using dopamine agonists such as pramipexole and ropinirole. Most likely less so in people who are taking rotigotine, because it is a 24-hour patch as opposed to an up and down. So we do tend to see this much more significantly with pramipexole than with the other two medications, and certainly more with the short acting than the long acting. It can vary in terms of how it manifests, of course, and most people don't have all of the experiences. It's usually one or the other in terms of what the impulse is. Men usually are more likely to experience gambling and sexual impulses compared to women, more likely experiencing overeating and reckless shopping, we will say. But it can occur in people with prior or without prior addictive behaviors. Of course, it's a little bit of a higher risk in those with prior addictive behaviors. It is more risk in a younger patient and those on a higher dose of levodopa. It is associated with greater disease duration, but not necessarily with how somebody's doing in their movement symptoms or signs. Paradoxically, it also is associated with apathy, which is one of those strange kind of things where if you have apathy and loss of interest in things, then how do you also get an addiction to something that's bringing you a reward? And one thought process as to why that happens is because the whatever the behavior is that is the impulse, like let's say the video game, for example, is taking so much time and energy that that person then has no interest or motivation to do anything else but that kind of non-productive behavior. And there are possible genetic predispositions. Now, it's important to note that it's very common for people to not experience this as a symptom. That is to say, to not recognize it as a problem. And again, that is obviously the case with a lot of people without Parkinson's who are developing addictive behaviors such as gambling or alcohol, where they're really not recognizing they have a problem. I can quit at any time. I'm going to win the next round, etc. So it can therefore lead to devastating consequences to the patient and the family, especially when the family is not aware that there are financial or sexual risks being taken by the patient. But also, you know, frankly, when it comes to things like shopping and eating, it can be a little bit difficult to know where to draw the line between, is this a compulsive behavior that meets criteria for an impulse control disorder, or do we just have bad habits? So for example, I tend to rely on how the patient is describing their behavior, but I do ask if there's a family member who's observing to also give their opinion. And of course, there can be differences of opinion of that. So that does tend to result in some he said, she said sometimes, but you know, I think that we all have our moments of weakness, but there do appear to be certain cases where, you know, if somebody's having a pint of ice cream every night and, you know, a sleeve of Oreos every night, and, you know, a large bag of chips every night, then, you know, you can sort of get a sense from the volume of what's being consumed as far as this is a problem. When it comes to the shopping, you know, I think it may sort of be within the discretion of that person's financial situation. So if they are recognizing that they don't have the budget for X, Y, or Z, but they're spending $300-400 on, you know, vases on a monthly basis, that they may recognize, well, this isn't money that I really had or that I should be sending. And that actually points to another aspect of the shopping is sometimes it's not so much that they're buying, they're like looking, like spending, you know, 80,000 hours researching, buying a mattress online, but not actually buying it. You know, that's not necessarily, you know, that person may recognize that this isn't normal behavior for them, or their family member may say, this really isn't how they used to make decisions in their life. They wouldn't quote unquote obsess over things the way they are now. So I have had people where they'll do online shopping, they'll put things in their cart, but then they won't check out. So they're still kind of, it still counts as an impulse control disorder because they're really kind of getting stuck in the shopping phase, even if they've been able to at least mitigate the harm by not clicking the purchase. And going on from there, the ironic sort of misfortune is that when these occur as a result of dopamine agonist withdrawal syndromes, both the problem arises where the doctor may not be aware that the patient has a problem for months or years until something comes to their attention. And also those very same patients who are at higher risk of developing impulse control disorders are at higher risk of having a withdrawal syndrome if the dopamine agonist is taken away. So dopamine agonist withdrawal syndrome, or DAWS, can be experienced with fatigue, anxiety, panic attacks, depression, even suicidal thoughts. So it's a very serious condition and might be mitigated by a slower titration off or a tapering off, but can sometimes be very, very difficult to mitigate, even with very slow tapering, and therefore patients may you know, really get stuck on at least hopefully a lower dose of a dopamine agonist, but it can be very, very problematic. So I tend not to start a dopamine agonist in a patient who has a risk factor for in impulse control disorder. So treatment of impulse control disorders is, as I said, gradual reduction of the dopamine agonist. Unfortunately, there's not a lot of evidence that there's medications that can help for impulse control disorders. Counseling or cognitive behavioral therapy may be of use. In some cases, a family member may need to limit that person's access to finances if appropriate. There is a small study that suggested that amantadine could help for punding, but as mentioned above, it can carry other risks. And there's been some interesting data about DBS where the majority of people who have impulse control disorders and undergo DBS actually have improvements in those, although there are case reports of the impulse control actually getting worse after DBS, and there is a usually short-term period after DBS where patients can be more impulsive. So talking about the power of habit, this is from Charles Duhigg. I found it a fascinating book, not just about, impulse control issues, but also how to create good habits such as healthy diet and exercise routines. And this book is not a self-help book. It's not specific for Parkinson's patients. It's just making people recognize how many of our decisions are and our behaviors are very subconscious, and therefore trying to bring conscious awareness to things in order to make better habits or adjust bad habits. So the concept is that there is a reward cue routine pathway of cycle. So, in the example on the left, eating cookies results in a reward. Who doesn't love a cookie? I don't know anyone who doesn't like a chocolate chip cookie, especially if it's really warm, fresh out of the oven. We're all craving one right now. And so when we get that craving, then we actually crave more junk food or more cookies. And then when we feel hungry, we interpret that cue as it's time for more cookies. And so it creates this vicious cycle of it creating more and more. And also I would add in there the sort of emotional component of food habits. That's sort of a topic for another day, I would say, but guilt issues coming about self-worth, image, et cetera, et cetera. So we won't get too far into that, but just sort of that basic concept of external or internal cues, external or internal components of the routine. For example, the cookie jar. It's clear glass and it's sitting right there on the counter, and you're walking through the kitchen. What are you going to see? You're going to see that cookie, compared to somebody whose cookies have been put away on a high shelf, or somebody who just doesn't buy cookies. Like, something external might be easier to break that habit and kind of create a change in the routine. So on the right, what we're seeing is a shift or a change in the routine. So having a list of what are called slow carbs. So, a bowl of nuts or something like that. And then using that to obtain the same reward, and then also feeling more healthy and accomplished, resulting in the hunger cue being reacted to in a more productive way. So it's very important, though, that the reward be the same. So if, for example, we say, well, instead of eating a cookie, you should have, a piece of broccoli. Well, you're not getting the same reward out of that. Who likes, I don't know. I mean, there's a small subset of people who like broccoli, I guess, but it's not the same as the reward you get from having a cookie. So that's not really going to do as well of a job of extinguishing or changing that habit, because it's not giving you the same reward. So that's the concept. It has to be the same cue, the same reward. It's just that the routine and then the reaction need to change. So again, the book is not a self-help book, but it's absolutely fascinating. It's not just about how humans behave, it's also how societies behave. So I thought it was interesting. Okay, so moving past that to the dopamine dysregulation syndrome. So this is, again, rare, but it can occur in younger patients, young onset disease, and more often in men. But it's essentially a compulsive intake of dopamine, either the levodopa or less commonly dopamine agonists. So people can experience an extra boost of energy and productivity. And for some people, when they're taking their levodopa, if they're not actually feeling the motor improvement, but it's more like they're just getting this kind of like an emotional boost or an energy boost, then there's a risk that that is more of a euphoric reaction to dopamine and less so the actual management of the deficit and the motor symptom. Therefore, as their levodopa wears off, they may feel dysphoria, meaning negative mood, and very early wearing off. And then these patients tend to self-medicate with increasing frequency and dosing and hoarding even of medicine, preoccupation with taking medicine despite having side effects or dyskinesias. And so this is obviously very difficult to differentiate between, well, what is sort of that normal, or excuse me, I should say common process, I wouldn't say normal, but common process of as the disease is progressing, the medication isn't lasting long enough and there's wearing off happening and people are needing to take their medications more frequently versus an actual dysregulation syndrome. And some of the clues are how early it begins in the course of the disease, how early it begins in terms of patients reporting that their medication is only lasting an hour and a half or 2 hours, and they're not really showing that motor deficit on the exam. That's a little bit of a concern. Again, this is really only in a subset of people, but the treatment can require people sort of setting limits on the dopaminergic medication and maybe adjusting, let's say, anxiety by treating anxiety as opposed to treating anxiety with levodopa. Or if somebody's feeling depressed when their dopamine is worn off, maybe it's a sign that they need cognitive behavioral therapy or an antidepressant as opposed to more levodopa. So this is very tricky, but it's important for people to be aware of this entity, because if it's not checked, then it can result in just higher and higher and higher doses of levodopa, and that can be problematic. So I think I covered everything that I wanted to. Obviously, you know, this, again, as I said before, isn't something that everybody's going to experience. But I hope that it was of use to people. And, you know, and I also want to speak to those of you who may be listening who are aware of all of the problems and really wanting kind of more of a, what's the magic bullet, what's the cure for these problems? And unfortunately, these are very, very challenging symptoms. So it's very personalized and important to talk to the treating clinician.
Thank you so much, Dr. P, for very eloquently talking about behavioral issues with Parkinson's. I think this is something that's very important to our patients, and also very scary for both patients and families. So thank you for opening up this discussion today. I really like when you started and you defined psychosis, and I think that can be very helpful for families and patients too, where you define psychosis as this disconnect from reality, because the word psychosis can be very scary for families and patients, and actually just the word can trigger a lot of like emotions too. We've definitely seen that.
Yeah, I tend to start, you know, some of you may have heard me ask the question as, are your eyes playing tricks on you? Are there times where, you know, you're seeing something in the shadows, or if you're not sure about what you're seeing? So I try to avoid the P word and sort of frame it in as non-judgmental way, because, you know, one thing that we've learned in the literature is that, you know, doctors really didn't recognize how common these symptoms were, because if you don't ask your patient about it, they're very unlikely to bring it up, because they're very worried about, you know, being thought to be crazy, you know, to use that word. You know, sometimes it's scary, sometimes they don't know. Yeah, I know that a lot of our patients were first they were first brought awareness of this condition with the Nuplazid commercials that they were seeing online. And the way they frame it as up to 50% of patients can experience hallucinations and delusions made people feel like, oh my God, I have a 50-50 chance of going crazy. Like literally that's their thought process, but they were framing that 50% by looking at a study where they included these minor fleeting passage, etc. Sometimes you see a second dog or whatever, and you blink a couple times and it goes away. And I think the vast majority of people who are experiencing that would not frame it as particularly problematic to have that experience. So I think that it was a good thing that people became more aware of it and more, I think, perhaps comfortable asking doctors about it, but really it kind of was framed in a very scary way.
I definitely do remember that commercial. We got so many calls when that commercial came out because the commercial tended to be on the more scary side of scary figures coming out, where what you're saying is what is sometimes experienced by the patient. It's really very benign. It's a misperception of things, sometimes just a shadow, wherein because that's already considered hallucination, but then there is that disconnect when what is portrayed as this scary almost like monster like coming on in the dark.
Right. And again, it can occur in a scary way. They can be very distressing, but that's really not 50%. That's a much higher percentage, and therefore I think it was a misrepresentation. I do want to remind people that if they would like to write their question down in the Q&A, that we can try to address any questions, so that's not just me and Giselle chit-chatting here. I know I did see a question coming through about apathy. We did talk about apathy. Dr. Diaz gave a talk about apathy, and that should be up on our website. But apathy can be very challenging and problematic in terms of motivation and interest level. And we find that if there are ways for a family member to nudge or set up a schedule where there are activities happening, that can sometimes be of help. There are medications that have been tried for apathy with really quite varying degrees of success. So I'd encourage you to look into that talk from Dr. Diaz.
Let me just look at the chat. Do you want to respond to this, Dr.?
Yeah, sure. So question was about a family member who was very frequently having conversations about flying and wanting to discuss like driving to the airport, packing. So that can happen where people sort of almost get stuck on a topic. And it's not even necessarily like that's a behavior, like it's not necessarily like they're leaving the house, but it's just like almost like a repetitive conversation. But yeah, I think that sort of counts as a almost like a compulsive kind of, and sometimes that has to do with memory. So if somebody really doesn't remember the conversation that was had, then of course that can cause a repetitive conversation. But sometimes it's like anxiety or like preoccupation. A lot of my patients will tell me that, in preparation for the appointment with me, there were 5 questions, every day. When is the appointment with Dr. Petrosian? When are we going to go? When are we going to leave? I don't want to be late. And, frankly, I think that it's that sort of, there's no magic for that, right? That just has to do with the patience of being that care partner. And again, recognizing that this is coming from some place of anxiety or some, emotional state, and reacting to that emotional state. Like, it sounds like you're really stressing out about this trip that's coming up. We've booked the ticket. We don't need to pack yet. I will remind you, Unfortunately, often that will not last very long. So maybe need to be repeated. So it's really, there's no magic to that. It's just a matter of trying to take that deep breath and to remind in a very non-judgmental way. You know, not, you don't need to say, oh, I already told you this yesterday, or, oh, we already talked about this, or don't you remember we talked about this? None of that's particularly helpful. It's more just like, oh, it seems like you're really, you know, stressing out about this trip. You know, let's I will tell you when we're ready to go for that. And really, again, a lot of that comes with the anxiety that comes with disorientation of dates, right? Like, when are we going? You know, you have to have a sense of how much time is there between now and October. And if you're not sure if it's July or June, it can create this sort of sense of anxiety. So again, important to talk about individual questions with one's provider, but if there's an opportunity to help for anxiety, or try mindful awareness or meditation techniques, or again, redirection, you know, I'll tell you when it's time to pack. Why don't we go, you know, online and look for, you know, what we're going to do when we're on our trip, or why don't we download a book that we can read? I don't know, things like that, where you're trying to redirect there.
Dr. P, you also brought a very good point in one of your slides with regards to acute changes to notify your physician, because sometimes with the acute confusion or hallucinations, it might point us to something else too, such as infection. So that is also one of the things to bear in mind too.
Okay, so I guess there was a re-clarification about that particular case. It was a case where actually there wasn't an upcoming trip. It's just that they believe that they are going to go to that location. Yeah, that's tricky. But again, I might say something like, oh, I recognize that you are expecting to return to Boston or wherever. You know, why don't we, again, it's just really just about responding to the emotion. So the logical reaction to it would be to explain, this is why you are not going, or this is what isn't going to happen or is going to happen. And it's not necessarily going to be as fruitful as just sort of recognizing or acknowledge the emotion that is driving that conversation. So, you know, I recognize that you're feeling unsettled, or you're feeling like you want to go home. That's a tricky one. We have a lot of people have the delusion that they feel like they're not at home. When can we go home? We hear that a lot, and that's really hard. So, you know, people will say, you know, you are at home, and then it doesn't settle them. So usually I would try a kind of a redirection technique, make sure they're getting adequate sleep, make sure anxiety is being managed in other ways. And again, in certain cases that may include medication for anxiety, but there's also data on, you know, like yoga and Tai Chi and mindful awareness, and again, other kinds of activities that could help as a redirection. But I would try not to engage it for too long, because then you're sort of feeding into it, you know. So acknowledge the emotion, you know, maybe say something like, hey, why don't we go look at pictures of Boston, or like, let's go online and find some, you know. And this, again, they may not work in all cases, but yeah, it's tricky.
Dr. P, will take one more question. There's one in the chat. Can these symptoms only develop in late stages, or if you don't have it in the early on, do you expect to experience them still?
Great question. I mean, unfortunately, we don't have great ways of predicting who will experience these kinds of things. But yeah, I think that if there are early stages of minor hallucinations, then it is more likely that that is a person who may go on to develop more formed hallucinations or more problematic hallucinations. And if they don't have any of it, then they may feel a bit comforted, but, you know, I don't think that I would be able to say, oh, well, this is never going to happen to you. But just the fact that I think a way to frame it is, something like 60% of people never experience hallucinations. So for whatever that's worth. So I do think, that kind of to end on the note of, well, what are we doing about preventing these things? And I think at the end of the day, it all comes back to how do we prevent Parkinson's from progressing in the first place? Because this, again, as we've said before, this isn't a dopamine thing where we can just give people more dopamine, right? So how do we prevent this from happening is we need to find ways of treating Parkinson's at earlier stages with treatments that are actually preventing the disease from progressing. And we know that exercise, diet, and other lifestyle factors play a role in preventing progression of Parkinson's. So best of luck to everybody. And, please reach out to your doctors if there's more specific questions. Thank you guys so much for joining.
Thank you so much. Take care. We'll see you again next month. Back on our regular first Monday of the month from 12 to 1. See you, everyone. Thank you so much for being here today. Take care.
Okay.